This presentation is exploring the identification and basic management principles of some high-risk presentations of abdominal pain in the pre-hospital setting. In particular, it will look at the presentation of ectopic pregnancies, dissecting AAAs, and the elderly as a high-risk patient group. It should be noted that all of these presentations now fit within the clinical flags of the Ambulance Victoria Clinical Practice Guidelines. Ectopic pregnancy is a red flag, meaning that the patient must be transported by ambulance and AV clinician contacted if they decline transport. Abdominal pain in general is now a yellow flag for all adult patients within the AV CPGs. This means that any adult patient presenting with abdominal pain must either be transported or advised to attend hospital or GP within 2 hours. If they are unable to do so on their own, they must be transported via ambulance to ED. Elderly patients are highlighted in the general notes portion of the clinical flags for the increased risk they present in potential diagnostic error, likelihood of deterioration, and the potential healthcare barriers they face. An ectopic pregnancy should always be considered in women of childbearing age presenting with abdominal pain, especially when syncope is also present. It occurs when a pregnancy develops outside of the uterus, most commonly in the fallopian tubes, but can also occur in the ovaries, cervix, or abdominal cavity. Most are discovered in the first 2 to 12 weeks of pregnancy, but become life-threatening when they rupture. Some of the signs and symptoms include that of early pregnancy, morning sickness, absence of a regular period, and syncope. However, severe pain, hypotension, tachycardia, and vaginal spotting or scanty bleeding are findings that may indicate ectopic pregnancy. Ectopic pregnancies are sometimes referred to as the great imitator, as there are a number of differential diagnoses. These can include ruptured ovarian cysts, pelvic inflammatory disease, endometriosis, appendicitis, and miscarriage. Risk factors include any history of pelvic inflammatory disease, previous abdominal surgeries that may have left lesions, previous ectopic pregnancies, fertility treatments including IVF, and use of intrauterine contraceptive devices. These patients are a true emergency and need to be transported without delay to an appropriate receiving hospital with obstetric capabilities. In the pre-hospital, our management should include IV access, pain relief as per the Ambulance Victoria Pain Relief Guideline, and consideration of fluids in line with any hypertension. An abdominal aortic aneurysm, commonly referred to as a AAA, occurs when the arterial walls of the aorta thin and weaken, causing that section of the vessel to bulge outward like a balloon. An aneurysm is classified as a permanent expansion of the vessel to 1.5 times its normal size. This is caused by arteriosclerosis that develops in the vessels due to the effects of chronic hypertension, calcification, or atherosclerosis that leads to weakened, stiff vessels. Additionally, collagen and elastin in the medial layer of the vessel both decrease with age, resulting in a reduction of strength and recoil of the vessel. Even in a healthy person, the levels of both these decrease as the aorta moves away from the heart. Hence why the most common location of aortic aneurysms to develop is just below the renal arteries in the abdomen. Once the vessel ruptures, it has a high mortality rate of up to 80%. Typically, prior to rupture, they do not produce any symptoms. If anything, there may be a pulsating sensation or an ache deep in the abdomen or back. Once they rupture, they can cause severe tearing or knife-like abdominal and lower back pain, along with profound hypertension and syncope. They can also present with nausea, dizziness, and shortness of breath. Another possible feature is unequal blood pressures between the left and right limbs due to reduction in blood flow to any vessels that are bypassed by the dissection. Therefore, the patient's accepted blood pressure for management is the higher reading that is obtained. A patient may be hemodynamically stable if the bleeding is temporarily tamponaded by the retroperitoneal tissues. This can provide a window of opportunity to treat the AAA before the patient deteriorates. If the rupture opens into the peritoneal space, however, the massive internal hemorrhage can be fatal. Differential diagnoses for AAA can include acute myocardial infarction, pulmonary embolism, GI bleed or peptic ulcers, gallstones, diverticulitis, bowel obstruction, appendicitis, or pancreatitis, among others. When differentiating between these, the distinctive features that indicate a likely AAA are the characteristic severe sudden onset sharp pain, unequal blood pressures and pulses, and migrating pain downward as the dissection progresses. AAA is significantly more common in men than women and increases in prevalence with age. Other risk factors include family history, smoking, hypertension, diabetes, and abnormal cholesterol levels, essentially all risk factors for atherosclerosis. A rupturing AAA is a highly time-critical emergency. Ambulance management should prioritise quick transport with early notification, IV access, pain relief, and fluid management under the hemorrhagic hypovolemia guideline. Avoid deep palpitation of any pulsating masses as they are fragile and paramedics could inadvertently worsen the rupture. As fluid resuscitation for dissecting AAAs is managed under the hemorrhagic hypovolemia guideline and considered in ectopic pregnancies, we will briefly review the guideline now. The guideline specifically states that AAAs are to be managed under it, and therefore we should tolerate a systolic blood pressure of 70 millimeters of mercury or greater for up to 2 hours. With a systolic blood pressure less than 70, time-critical transport should be prioritised with a bolus of normal saline 250 ml IV given. This dose can be repeated to a max of 2,000 ml as required, titrating to a blood pressure of 70. Minimizing the volume of fluid administered is required to maintain perfusion of the vital organs whilst minimizing the development of coagulopathy, acidosis, and hypothermia as a result of excessive fluid administration. In patients where blood pressure is difficult to ascertain, a blood pressure of less than 70 is often accompanied by absent radial pulses and decreased alertness. The elderly patient presenting with acute abdominal pain has a mortality rate of approaching 10%. Aging results in a number of changes, including decreased intestinal motility, decreased production of digestive enzymes, decreased liver function, decreased renal blood flow and glomerular function, along with increased risk of atherosclerosis. This places geriatrics at a higher risk to a number of diseases, including but not limited to AAAs, GI hemorrhages, bowel obstructions, diverticulitis, appendicitis, and cholecystitis. Their pathophysiologies are often difficult to diagnose, even once in hospital, due to the physiological changes that occur with aging, resulting in less predictable changes to vital signs, atypical presentations, and unreliable physical examinations. Once in hospital, they are more likely to require increased testing, imaging, and consultant services, and are also then more likely to require surgical treatment to manage their disease processes. It is therefore imperative that we transport these patients to hospital for further investigation. Here are the sources for this presentation. Thanks for watching. I hope this has been an informative reminder about some of the high-risk abdominal pain presentations that we can see in ambulance. If you have any questions or feedback, please feel free to leave a comment below this video.